why patients leave. It's a very important topic for a couple of reasons. One, commercially, no therapist wants patients to leave. It's a loss to the therapist. Professionally, speaks something deficient related to the therapist. Three, often therapists beat themselves up. Okay, what wrong did they do that the patients left them? More importantly, the professional standing of the therapist and the commercial aspect of it is secondary, but more important is often patients leave and don't go to any other therapist. That is especially true in India. We are not a therapy mature society in a way that a person knows that if he cannot go to X, he can go to Y.
Grateful if you give me a reference, your book maybe or citation. Ours is not a therapy mature society.
Yeah. It will be in my book. Yeah.
Please, sir. Please let me have the reference. I can.
Sure.
I intend to improve after our classes are over because I am inundated by clinical and hospital works and all that. But I'm serious about it. Thank you.
Yeah. So it's sort of very given the fact that we are not a therapy mature society. Often when patients leave, they actually don't leave the therapist, they leave therapy.
Yeah.
And that is something very difficult we must avoid. So it is very necessary, not only for the therapist, but also for the patient to minimize why the patient would leave therapy.
Yeah.
And therefore, we go into two kinds of causes here. One, causes related to the imperfections of the therapist, and for which the therapist must take the blame and must work to improve himself and not get into a position of narcissistic denial. On the other hand, there is no reason to beat yourself up and be masochistic when the patient is leaving for a reason which has nothing to do with you. So it is necessary to be very clear about it. When does the patient leave because of something in the therapist? And when does the patient leave for a reason that has nothing to do with the therapist? And in that case, the latter, there is no reason to beat yourself up. Often therapists do that. They beat themselves up that I must have done something wrong, that's why he left. So let us look into the reasons why patients leave. Obviously, list is long and nobody can make a comprehensive list. But what I have done here is concisely mentioned 50 reasons, 50, why patients leave. And I have categorized them in 5 different groups. So let us look at them. You can divide it into 6 different categories, not 5, sorry, 6 different categories. The first category is related to entry, how the patient has entered into therapy. And reasons related to that is category 1. Category 2 are reasons related to patient's personality. Category 3 is related to the structure and concept of therapy itself. What kind of therapy are you applying to what patient? Category 4, therapist. His flaws, his difficulties, his imperfect interventions, and so on. Category 5, the psychotherapy landscape, the way it is practiced at a particular stage where we find ourselves. And category 6 is related to reality. So let us look at the reasons. First set of reasons related to entry. The patient came under influence of the family members. Family members asked him to come for therapy, so he came, and he leaves after a few sessions. There's nothing that you can do about it. So you don't have to beat yourself up. If we go back, it's only point number 4 where you should focus on yourself, take responsibility, improve, not repeat the mistake. Other categories have little to do with you. Second reason, the psychiatrist asked the person to come for therapy. He did not want to come, and so he left. Reason number 3, law required the person to go for therapy. And he came, and he left. Reason number 4, school, college, club, or organization asked the person to go for therapy. And this is more true about students. Reason number 5, some celebrity talked about therapy and the person came because he liked the celebrity. Like in India, when Deepika Padukone said that she had depression and she had accessed both medication and therapy, many girls wanted to go for therapy just because they wanted to be like her.
The love foundation.
One group of patients will come because they are expecting miracle from therapy. Another group of patients will come because they expect a medical model, that you prescribe them something to do and its problem is solved. So instead of taking a tablet, they want an action to be prescribed, that you do ABC and it's solved. So they come with a medical model in mind. Some people come with a 1 month horizon, that I will get back in 1 month, or let me see for 1 month what happens. Some come to therapy to ask what to do. You give me a prescription. Some come to therapy to learn that let me do it all by myself, just tell me what I should do at home. And many the dependents will ask for what to do, and the schizoid and fragile narcissists will ask for, give me something I can do on myself. Why can't I heal myself? Why do I have come to you? One group can also come because somebody likes the therapist and is chasing the therapist. And when the therapist does not fall, the person goes away. Another group comes because they are just lonely. They actually need a friend, but they are nobody they can befriend. And they don't want to go through that psychological process again. So what they seek is friendship in therapy. Okay, they come to you because they want a friend. They don't want to get out of loneliness. They don't really have a pathological issue. So when patients come to you out of any of these reasons and they leave, after a few sessions, there is no reason for you to beat yourself up. These are entry-related issues, and if patients are coming because of this, chances that they will leave after a few sessions are very high. So these are entry-related issues why patients leave. Now, patients' personality-related issues why patients leave. Patient is narcissistic, it's very difficult for him to continue in therapy. First, they don't come. Second, if they come, they fight and they leave. Third, if they can't fight and leave, if you are too skillful, they will find some reason of non-performance or time or cost or something, but they will avoid. Or at the least, they will ask you, give me something which I can do to myself. Why can't I do to myself what you are doing to me here? what is that tool that only you can use and I can't use? So another situation, you get a narcissistic patient, fragile, you get into a cohesion mode of holding. Until you are holding, the patient is fine. The moment you start getting to the core of the patient's pathology, he gets out of therapy. So the first patient is narcissistic, second patient is fragile. Patients may be too fragile to go even for mild therapy, as we saw in Kernberg's classification of patients. That you can have one group of patients which are just not cut out for any form of psychoanalytic therapy, not even cohesion. So the patient is too fragile for any kind of psychoanalytic work. He may be okay with other kind of approaches, but not psychoanalytic approach. There is a mismatch between the fragility of the patient and the psychoanalytic approach. Patient may be too lazy to come, to be with you, to talk. So either it doesn't come. Yeah, please.
Sir, please, thank you. Can we actually assess a patient's fitness for therapy before we begin? Like we mentioned some time ago, the ego strength. Or when we were students, we were taught that generally people who should be referred to analysis or therapy are yavis, young, attractive, verbose, intelligent, and sophisticated.
Correct. Correct.
And that should be matching. So if there's something like ego strength that can tell us that you are fragile.
Yeah. So some tools help us. There can be tools which go into fitness of a person for psychoanalytic work. May not be very popular tools, but some tools will be there. Ego strength, definitely there are tools to measure ego strength. More than that, the case history of the person and his encounter with you in the case history session itself is a very good indicator. The case history can tell you about the fragility. In face of what events has the person disintegrated? Yes, please.
I'm a great fan of history and eclectic concept of normality. But the courts won't accept that. If I have to say that I administered this test and this was the result which showed fragile or
Yes,
whatever, then
true, true.
some of the tools, if you could just share, that would be great.
I'll do that. I'll do that.
Look, please.
Because law is a different cup of tea altogether.
Yes, yes.
So patient is fragile and or too lazy and leaves after a few sessions. The patient is not psychologically oriented. He doesn't want what is all these thoughts and actions, behavior and feelings. Give me a pill. I can just take that pill or ask me to do something. But don't ask me to talk and think and go in the inner world. So that is another group. They are not psychologically oriented. So they will leave it very soon. They might like behavioral therapy. They might like active meditations, or they might just not like any form of active healing. They may just like passive healing of allopathy or homeopathy. Regression is too heavy, especially if you are doing it on the couch and the regression is too heavy, even without interventions from your part, even without the person consciously having gone into too much of material insight. The pathology is too heavy, like extreme forms of depression, extreme forms of psychosis. It's very difficult to hold people in therapy. Unsuitability to therapy. Some just don't like this whole unstructured business. So they want a clear structure. So they may not like psychoanalysis, but some may not like therapy per se, any form of therapy. and they would like to have pills, and even if they have side effects. I'm reminded of what Dr. Hegde says, that there is there may not be a pill for every ill, but there's definitely an ill for every pill. So,
Absolutely. If you don't mind, I can say a couple of things.
please.
I was seeing an IIT engineer, or she was a master's, not engineer. Uh, she said at one time, stop giving me therapy. I will take therapy from my Swamiji. You just give me medicines.
Right.
Second patient was borderline, severely borderline, and I was very young in practice. And he said, stop interpreting, just medicines. And there was a third patient who said, I have lost it just now. I'll come back to it if I remember. Yeah.
So
But there are people who say that don't give us your interpretations.
they come and tell you, I don't want to go into what I did my childhood, what my mother did and father did. You just give me a tablet.
So,
when the person thinks of coming to therapy as a defeat, then why can't I do it myself? Why do I have this first in the first place? So first, why do I have the psychological problem at all? How can I have it? And second, in case I have it, why should I need somebody else to solve it? It's a defeat. Why can't I do it myself? Some people have extreme shame either of admitting to have a problem or talking to somebody about their innermost secrets, or in feeling emotions with somebody. All the three categories are different. You will have one category which they will feel ashamed of having a pathology and having to come to therapy. Second category, they will have shame related to admitting to events of their life, cognitively speaking. And third, there will be a category where they're okay with the first two, but they can't feel in front of anybody else. I can't cry in front of you. I can't feel angry in front of you. You look that side, turn back, and then maybe I can feel my feelings. So there is a different manifestation of shame. There may be infatuation with the therapist which cannot be resolved. And the patient may leave. And this happens many times if the therapist is a male and the client is a homosexually oriented individual, and he starts developing liking for the therapist, and he knows in the heart of his heart it's not correct, and he does not bring it up out of shame, does not bring up for discussion, just decides to leave the therapy. Some people come with a loneliness issue and they feel it's not solved in therapy. And some people come out of a legal problem, that they come to the therapy because they want that certificate for some legal purpose. And then once it is done, they leave therapy. Or in case of loneliness, they come for loneliness, but in real life, they meet somebody, loneliness is taken care of, and they leave. So these are patients' personality-oriented issues, patients' life-oriented issues, because of which they leave therapy. And if they leave out of any of this, the therapist does not have to beat himself up. It's a very different
exchange operation. This happens frequently. Patients, once they obtain the certificate that this fellow has gender dysphoria and gender identity disorder, is recommended the surgery. They vanish.
True, true. So they are in therapy not for therapy but for a certificate. They come to it because just is legally a necessity.
Yes, sir.
Now the therapy oriented issues.
15.
Yeah. The frame may be too tight or too loose for somebody, and the patient may leave either because the frame is too tight or too loose. Like somebody comes late to all the sessions and you start interpreting it and insist indirectly on coming on time. And the pathology because of which he's coming late is so strong, he just can't do it. And he leaves it because it's too tight a frame for him. Somebody who comes with anxiety, with disintegration, and you don't tighten the frame, you allow the session to start early and go on later, and he finds there is no structure to hold him. He still feels too much of freedom is a leaf in the wind situation. So the frame which should be holding his anxiety, providing him a structure in a completely disintegrated, fragmenting inner environment, for him it is too loose. So too tight, too loose a frame, and the person leaves. Type of therapy. Somebody wants a Jungian type of therapy and you start with a Freudian Kleinian approach and he leaves. And he seeks out a Jungian therapist and he stays there for quite some time. Destructive affect mobilization. In the enthusiasm to mobilize affect and release it, have a quick, deep, voluminous catharsis, therapist may mobilize too much affect which the patient cannot bear. So what I call destructive affect mobilization, damn. Always say damned if you dare. That because of this, the patient may leave. It's beyond his capacity. Speed is too fast or too slow. Transparencies which cannot be resolved are not brought into discussion. Like transference of a father against whom there is huge anger, and then the patient feels, I have to protect the therapist from my anger. So earlier there was a positive transference because of which he feels the need to protect the therapist. And now the negative transference has come. He's terrified of what he will do to the therapist, what this transference will do to the therapist, and he stops coming. Projective identification, that the person has done some projective identification and cannot be contained by the therapist. Or he is afraid unconsciously of the projective identification he is doing. Or, yeah, so this is from his side. That he is afraid of his own projective identification may not destroy the therapist. Just as a transference may not destroy the therapist. The patient has a thought-action confusion deep in the unconscious, where when the therapist asks him to feel his feelings towards the significant ones, he feels that what he thinks in his mind will actually happen in reality. And this may not be essentially psychotic. You may have a perfectly neurotic person in whom, at an unconscious level, this is going on. That you are dealing with the neurotic state, but in the unconscious, there is a psychotic belief that my thinking equates action. Too much guilt is brought up by therapy, by self-reflection. This can happen, let us say, a dependent lady who used to be in a relationship before marriage. And after marriage, she is not able to forget it and move on because of the dependence. And she goes for therapy. And in the first 2 sessions itself, the therapist tells her about the cycle of dependence. And now she feels so guilty because she knows that all that went wrong with the person before marriage was because of her. Till now, she could project it onto him, it is because of him. Now that she knows it is because of me, enormous guilt comes in. and she may leave the therapy because the guilt is too much. We have mobilized far more affect than she can bear. Some people are afraid of attachment and separation, especially those with histrionicity or schizoidal nature, even narcissistic nature. That the moment they start getting close to the therapist, they eject out because for them attachment is too threatening. They are terrified of the pain of separation when it happens. Some patients leave because they feel confidentiality is not safe.
The schizoid may be afraid of closeness itself rather than separation
Yes,
because there is fear of engulfment and annihilation and
correct. So the
in,
The closeness fear can be related to the separation post closeness. It can be related to merger. It can be related to annihilation. It can be related to entrapment and devouring. So all these are the closeness related, the whole spectrum of closeness problems.
yes.
So one group will leave because they fear confidentiality may not be preserved for whatever reasons. Maybe they feel that while they are going in, everyone knows where they are going into. Or they fear just as they come in and somebody is walking out and he is a known person, what if he comes to know? Or somebody in his family circuit or friend circuit is in therapy circuit also. Some feel the freedom is not enough. Why can't we have times which are convenient to me every day? Why should I have fixed time every day? So this is the freedom related issue. Some will feel the therapist is very rude if the interpretations are too harsh or perceived to be too harsh. Some will feel it is very inhuman that you are only into difficult part of the psyche, not into the positive, happy part of the psyche. And it's constant fault finding and trying to get it healed. And that's a very inhuman process. It's not a human process. Very small group will feel this, but there is a group that I am much more than my pathology. Why do you always talk of pathology?
I know a student who used to say about our teacher that the teacher is only interested in our pathology.
Correct. Correct. One group which is very socially oriented thinks of this as a very unsocial enterprise. That what is this? We can't meet, we can't shake hands, we can't have a cup of tea, we can't even talk like normal human beings. You have reduced yourself to a machine and myself to a patient. So this is one group. Another group is where the results are not coming, or the patient feels results are not coming, or he feels it will not come, or somebody tells him it just can't come. So whatever be his belief, can't come, is not coming, cannot come with this therapist, cannot come with this therapy, whatever his belief, but results can be one area why the anticipation of results on the negative side, the patient may leave. Therapist-oriented reasons. The reputation of the therapist or the knowledge of the therapist may be seen as inadequate, or it actually may be inadequate. The training of the therapist may not be proper, in which case, because of technique problems, knowledge problems, wrong interpretation will happen, wrong type of interventions, wrong language, wrong timing, all of it can happen. The therapist has some sort of unsuitability. Like he's not cut out to be a therapist. He's too much like a military general. Either he's too liberal or too strict, unforgiving. So there's some kind of a persona in some range that you need for a therapist to be. Therapist may not be capable of holding the difficult feelings of the patient. There may be a containment problem. Therapist will be acting out either something coming from the patient or something coming from himself. Like if the therapist is lonely himself, he may start sending good morning or happy new year messages to the patient. The therapist cannot hold the frame. Either he's too afraid of the patient leaving or is himself not convinced about the benefits of the frame. So either he holds too tight, too loose, frame holding becomes a problem. He is not capable of contextualizing, customizing the frame for the patient. The calibration of interpretation or catharsis may be missing or inadequate. Therapist may be approaching too slow or too fast for catharsis, or in case of interpretations. Instead of going from the leaf to the branch to the trunk to the root, he may be directly going to the trunk or the root. Therapist has got too much supervision and now he is completely in conformity. The supervisor is in the room in his mind and he is not able to do anything freely and he appears very artificial and unnatural. And the patient can make it out. See, intuitively, you always know when somebody is artificial, when somebody is parroting what the supervisor told him, because we know it is not he speaking, it's somebody else speaking.
Professor asked me after reading these psychometry test reports. In this language, does this originally does it come from the psychologist? Because this language doesn't appear to be the psychologist who conducted the exam. She seems to have copied and pasted, cut paste kind of interpretations.
Correct. Correct. So when the utterances of the therapist become completely rootless and artificial, like they have been acquired by rote learning and conformity to the supervision, the patient is able to make out in some way or the other. And it creates a disinterest in the patient. The ambition of the therapist to directly go to the root of the whole problem, instead of moving sequentially from the leaf to the branch, the trunk to the root. When one is young, often one can think of directly going to the root, that at the end of the case history, if I know the pathogenesis, I am good enough to do it. That just by looking at case history, I know the pathogenesis, I know the root. Why not go straight to the root and solve it once for all? And that ambition creates such discomfort in the patient that he runs for his life. So there's too much of ambition to compress the therapy process beyond a point is also the reason why patients run. The knowledge and the skill of the therapist. He may know only one school and he's dealing with a problem which is appropriately addressed by another school, which he does not know. And he tries to force fit his knowledge and it does not work. And he keeps insisting and the patients know they are talking past each other. That he can't relate to anything the man says. Knowledge deficit or skill deficit. He has the knowledge, but he does not know how to conduct therapy as a session. How to convert his knowledge into intervention. How to use proper language. How to weave the psychoanalytic theory into a ordinary conversation. Mistakes that the therapist makes. Patients are usually very liberal with mistakes. But if you just make too many or repeat the same thing over and over again, this may become one reason. Transference or projective identification of the therapist onto the patient. If the therapist is not sorted out inside, he may just do the reverse. He may put something in the patient and then the patient becomes a therapist for the therapist. If, let us say, the therapist does not have has an unresolved histrionicity and he puts something seductive onto the patient, and the patient is now trying to control that seduction. Now it's the reverse. The patient has become the container and the therapist has become the projector. And the patient has become the therapist for the therapist. There is a very popular paper on this. The patient is a therapist for the therapist. So, if the therapist has not worked on himself and not sorted out inside of him, his own transference and projective identification can disturb the patient. And it may result in an unknown, unarticulated, ununderstood instance of living. When we were doing transference and projective identification, we said actually there are two transferences, two counter transferences, and two projective identifications in the room. But from the therapist, it should be less in frequency and very less in intensity. In an absolute sense, nobody can be a blank screen, but it should be insignificant. If intellectual development of the therapist has not taken place adequately, like he knows only his area and somebody intellectually oriented comes in, there is a complete mismatch. The therapist is not capable of engaging in intellectual conversation. And the patient feels completely ununderstood and he is not ready to accept only those points which connect to the unconscious or the psychological theory that the therapist brings in. So in that sense, the patient makes an assessment of the therapist that intellectually is not of a very high order, and that may affect his choice of therapist. He may go somewhere else. It can also affect the projection of omnipotence and the series of events which follows from there. Self-development. If therapist has not worked on self-development beyond intellectual development, so if he has not dabbled somewhat into mysticism and spirituality and not worked on himself, it comes out and many patients find it inadequate. Especially if they come with a background of self-work, mysticism, spirituality, that group of patients. And such patients may leave and find a therapist of the type they want. Positivity, safety, and cheerfulness. If these are absent and the therapist himself looks depressed, he himself looks gloomy and angry, holding on to his anger, containing it somehow with great effort, those are very difficult to accept therapists for a group of patients. So these are the reasons where the therapist himself has to take responsibility and work upon it. You can't escape by saying it has nothing to do with me. Other categories, you don't have to beat yourself up. On this point, you don't have to beat yourself up, but accept responsibility and work on it. The landscape. The classical psychotherapy landscape works on the trinity of thought, affect, and behavior. It does not go into the aspect of energy and holistic healing. And one group of patients wants precisely that. So that may be a reason for leaving for one group. Another group wants holistic living and healing through holistic living. Third group feels it's too hierarchical. Equality is absent, and they would like a more existential humanistic architecture where self-revelation happens from both the sides. And they may not like the hierarchy and the confidentiality of the psychoanalytic process. So they may leave.
Would you say broken fathers, broken sons, where they profess kind of self-revelation and equality?
Right.
Uh-huh.
So the self-revelation is what they want,
Uh-huh.
the sense that they feel that the
Uh-huh.
is also a human being like them, and both of them are a part of the human condition, and both of them are fumbling through life because no human can do anything other than fumble through life. It's only very few human beings much later in their life have a very clear route of what to do. 99.9% will be fumbling through life. As they say, fumble, tumble, and then bumble. So they would like a more existential approach other than a psychoanalytic approach. One group would like more of do it yourself, like CBT. And they don't like that psychoanalysis does not give you anything to do it yourself. They want between the sessions to be given tasks. And on this point, I think they are right. We should be devising tools and tasks on which psychoanalysis is deficient because it evolved in an era of 5 days a week or 4 days a week. So there was no need to give any assignment of do it yourself. But today, when practically it is not possible 5 days a week or 4 days a week, and you are looking at 1 day per week or 2 days per week max, I think it's a just demand that we should be devising some exercises, tools for do-it-yourself application between two sessions. One group would like a structured journey, and they find psychoanalysis too unstructured. They want clarity that let us have 15 sessions only on this problem, and then 15 to 20, 16 to 25 on that problem. And let us do it that way. Or if we are looking at anger, let us do 10 sessions only on anger. So that kind of structured approach they want, which they can find in CBT, but they cannot find in psychoanalysis, so they leave. One group would like conceptual explanations, or they disagree completely with conceptual explanations. So if you say something, they say, I don't understand. Can you explain it to me? Why do you say this? And it can be something very deep, and maybe you don't have material from the life story of the patient or free association, and you have made an interpretation. So you can just say, okay, let us go ahead and see how it turns. Let us keep it open for the moment. They don't want it. They want a complete conceptual explanation, or they just can't get your explanations. Okay, how are you connecting the two things? I don't see any substance in that. Or they will say, don't ask me what does it mean. Because this is the whole way psychoanalysis works. On everything we say, okay, what does it mean? Meaning, what does it mean unconsciously speaking? So they are tired of what does it mean. Some will go because they don't have surety of results or predictability of results or even measurement of results they are convinced of. Or they have heard that results come too late or too little, or they don't. They have heard something very difficult about therapy. That is just a process without results. So whatever be the case, these are some of the psychotherapy landscape-oriented issues that you may just have a general feeling in society that therapy does not produce results. And in India, it's very popular, very common. Not only many people, but even many psychiatrists believe that therapy does not produce significant results. And this pervasive idea can affect the patient who hears it from 2-3 places, and worst of it from psychiatrists, because then he believes it must be true, then the results are not significant. So these are some landscape related issues that on the whole, the way the healing landscape is and how psychoanalysis finds itself situated in it and what are the perceptions about it, this whole landscape creates some reasons why people leave therapy. Last is reasons of reality. Some people will leave therapy for the sheer cost of it. That you have to come twice a week, which means 8 times a month, and it goes on for, let's say, 6 months or 1 year, and the amount is so high compared to their salary, they leave. Some leave because of time, that they don't have an hour to come, an hour to go, an hour of therapy. Because in the city conditions, so much of traffic, it practically costs you half a day. So many people don't have the time. Third group, the stressors are too high, living with them, and therefore whatever good you do in therapy is not enough given the constant action of stressors in their life. They are virtually living with stressors at home or at office. Or some even have situations of death or some accident of the past, which is a continuing stressor, the implications of which are a continuing stressor. One group just does not find suitability in terms of their lifestyle, their belief, their problem. Somehow they don't find therapy suitable or psychoanalytic therapy suitable. And some just don't have the capacity to bear psychoanalytic therapy. So these are like reasons of suitability also relates to the pathology they have. Many may feel that for my given pathology, psychoanalytic psychotherapy may not be the best. So these are reasons of reality why people leave. So we have seen the 6 categories, and in those 6 categories, 50 reasons spread out why patients leave. Obviously, there are more reasons, but I have just tried to put together 50 reasons. The idea is the same. If you understand them better, less people will leave. And in case they leave for reason not to do with the therapist does not have to beat himself up. And in case they leave for a reason related to the therapist does not go into a narcissistic denial and accepts his shortcoming and tries to work upon them. So, this is why patients leave. Next time we'll start with dream analysis. Any questions you have?
Sir, can I have your email ID so that I could send some papers? We mentioned a couple of books and I have located them. I could share the PDF with you.
Sure, please do. HV, H for holiday, V for victory. HV India, INDIA @gmail.com. HV.
Thank you, sir.
See you then.